Okay, so this is the knee series. So our standard series for the knee is going to be A to P, lateral, and intercondylar or tunnel view. So for our A to P knee, we're going to take a 10 by 12. ID blocker needs to be out of anatomy. I like to just be consistent with all of our knee views and just put it up. That way, when we get to tunnel or intercondylar and it says up, you've already been doing that. My central ray is going to be at the apex of the patella, and I have a 5-degree cephalic tube tilt. So the fun saying is a nickel for the knee and a dime for the foot, or 10 toes. So you have, that gives you a 10-degree tube tilt when we get to that view. So nickel for the knees, you're going to have a 5-degree cephalic tube tilt. Palpate for the patellar apex. Make sure our patient's leg is centered midline and parallel to the long axis of our film, just to keep everything nice and aligned. Push that in. I'm going to collimate to just under film size. I am still using the cassette tray, so we still need to be at image grid distance for our column for 40 inches and not tabletop. Make sure that the patient's other leg would not be in the collimation at all, just to be extra safe. Yep, no crossing the leg. Don't breathe, don't move. You can use a shield out of collimation over the gonads just to prevent any extra scatter. A to P knee. The next view is our lateral knee. So when we do the lateral knee, and a big mistake that happens on the practical is that as we have the patient turn to go on their side, you end up imaging the other knee, which will result in points off on the practical, because if I am x-raying somebody's knee, I need the same knee, so don't switch right and left. So as Dr. Zapay has, she wrote on her side, this leg can come in front of the knee, but I am still imaging the left knee. So the leg in front is not the knee being imaged. Send her back a little bit. So I'm gonna go right at the medial joint line for my central ray. The knee is bent approximately 30 to 45 degrees. I don't want the knee bent any more than that, because you're not going to be able to see the suprapatellar pouch, just know if there's a joint effusion or not. So this is good position for this leg. Dr. Zapay is just raising her leg to show you so you can get a better view. I still have a 5-degree cephalic tube tilt on this view. So I'm collimated from my previous view the same. Just make sure that if you moved your central ray at all, that you're still matching that cassette, and then your Mitchell marker goes in. If you can see light on the tabletop, put it right there. Okay, that is a lateral knee, final position. Okay, for intercondylar view, this is not the best, most comfortable position for your patient, but we do it quickly and efficiently so they don't have to be in a weird position for too long. So can you go on all fours for me? Yep. So we're going to a runner stance. So there are 2 ways you can do this one. The patient's on all 4. You can have them, if they are okay upper body wise, they can lean forward a little bit, and it helps get the glute and the hamstring muscle out of the way. If not, come back to normal. They can slightly extend the knee that you are going to x-ray. It's a little bit. Oh, and then if she slides down, she can hang her foot off a little bit. So that might be a little bit more of a comfortable position, especially if you don't want your patient holding with their upper body for so long. So I'm going to go 1 inch superior to the popliteal fossa. Make sure that her leg is centered midline. My ID blocker has to be up, but if I've been keeping it up this whole time, then I'm still staying consistent and I don't really have to change much. Still lengthwise, 10 by 12. I line that up. My Mitchell marker goes in. Don't breathe, don't move. So that is your intercondylar or tunnel view. You can go ahead and lay face down for me. For our last view, which is the sunrise view, your patient will lay face down, and then they are going to maximally flex this knee. Now, this case, it is helpful to use a strap, 1, to prevent patient movement, and 2, to get the full range of motion. So you can hook it around your patient's foot, hand them the strap. Now I have to line her up a little bit. Good. Now, I was able to just shift her knee slightly and still keep it midline, but if the rest of her body was angled quite a bit off, and then the femur and tibia weren't going to be exactly parallel with my long axis of my cassette, then I would have to shift her body over. here, so we're gonna go right at the patellofemoral joint. I have to move my cassette down slightly to match. That is your sunrise view.